Hello everyone, welcome to my YouTube channel Pathology Learning. I am Dr. Monica and in today's class we will be seeing about intracellular accumulations under the cell injury series. So what is intracellular accumulation? As the name suggests, it means that there is something accumulating inside the cell. So when will something get accumulated? Either when there is an increased production of something or when there is decreased removal of the same thing, right? Or another thing would be when there is a defect in the transport of this substance. Okay, so we have various accumulations which could be either pigments, lipids, proteins, or glycogen or glucose. Okay, so in today's session we will be studying about pigments. So pigments could be either endogenous pigments or exogenous pigments which are getting accumulated. So the best example of exogenous pigments would be carbon. Okay, so we'll see one by one. So the first pigment, as I mentioned, is carbon. So we all know carbon is seen in the a vehicle exhaust, right? So it is one of the most common air pollutant. So in the vehicle exhaust, we see these carbon particles, and when the person inhales this carbon, what happens? Here, this carbon particle which are actually black in color. So this black in color, these pigments will enter the alveoli. And in the lung alveoli, they are being phagocytosed by the alveolar macrophages. So these alveolar macrophages will then carry this carbon from their lung to the through the lymphatics to the lymph nodes. So since this carbon particle is black in color, grossly also, like we see in this image, this lung will appear black in color, and this is termed as anthracosis. Okay, so this is termed as anthracosis. And the lung, the lymph nodes, the hilar lymph nodes, which are also involved by this carbon deposition, they also appear black in color. So one of the diseases in which this coal or carbon particles get deposited is coal workers pneumoconiosis. It is common in coal miners basically, and it can present with various spectrum of diseases. The initial spectrum is the asymptomatic stage, which I called it as just a black lung or a anthracosis. So the next stage will be a coal workers pneumoconiosis, which could either be a simple coal workers pneumoconiosis or a complicated coal workers pneumoconiosis. So simple coal workers pneumoconiosis in which there is a pulmonary function is not that much deranged. But in a complicated coal workers pneumoconiosis, because of the deposition of these coal particles, that is the carbon particles, the lung will undergo fibrosis. So scarring of the lung tissue will happen. So the lung function will get decreased. So that is what happens in complicated coal workers pneumoconiosis. It is also called as progressive massive fibrosis. So we'll see in detail about these when we are discussing the lung chapter. So this is the histopathological image of the lung, in which we can see this black colored thing. No? So these black color thing are nothing but alveolar macrophages which have taken up this carbon particles. So both the images are representing the same thing. So these are all the this red color which I am highlighting. No, this is the alveoli. So these are all the alveoli surrounding which we can see this alveolar macrophages which are laden with the carbon particles. So this is the example of a black pigment, and carbon was an exogenous pigment. So moving on to the next pigment, which is lipofuscin. So as the name suggests, it is something related with lipid, right? So lipo means lipid. Lipo means lipid. So fuchsin was nothing but it means fuscus. Fuscus is called a brown pigment. Okay, fuscus literally means brown in color. Okay, so lipofuscin is a lipid pigment. So it is also called as a lipochrome, and it imparts a brown, yellowish brown color tinge. Okay, so that is why it is called as lipofuscin. It is also called as a wear and tear pigment. Why? I'll tell you shortly. So lipofuscin is actually a byproduct or a it is a telltale sign of free radical injury. We had already discussed about free radicals. So in that we saw that the free radicals, when they go and damage they tend to damage the cell membrane, right? So cell membrane was composed of lipids, phospholipids. So when these lipids are being damaged with the free radicals, they undergo something called as peroxidation, and they result in the formation of lipid peroxides. This is what happens as a result of free radical injury, right? So this lipofuscin are nothing but these are derived, lipofuscin are derived from phospholipids and lipids of the cell membrane. So phospholipids and the lipids of the cell membrane is the one which constitutes the lipofuscin, okay. So because of lipid peroxidation as a result of free radical injury, this lipofuscin is formed, and that is why it is rightfully called as the telltale injury of free radical injury, telltale sign of free radical injury. So it is also called as brown atrophy. Why? Because this pigment is actually brown in color. And why is it called as senile atrophy? Because as the age of the person progresses, as the patient ages, so the free radical injury will also tend to accumulate over the years, right? So when the patient ages, the free radical injury also accumulates, and that will result in the accumulation of this lipofuscin, which was the telltale sign of free radical injury. Okay, so that is why lipofuscin, the pigment, is also called as wear and tear pigment, and senile atrophy is a result of this lipofuscin. And this lipofuscin can also be seen in other conditions like severe malnutrition or in cancer cachexia as well. Okay. So remember, the constituents of this lipofuscin was lipids and phospholipids derived from the cell membrane. So how does it look in microscopically? So microscopically, it is a yellow-brown pigment, as the name suggests. I told it's a brown pigment. So it is a yellow-brown pigment which has a characteristic location, that is a perinuclear location. Okay, that is where this lipofuscin is seen, and it is a very finely granular pigment. So it can be seen in any tissue, but most commonly it is seen in liver or heart. So this image, the first image, is that of the heart cardiac muscle, in which can you appreciate this pigment here? So it is all in a perinuclear location, wherein it appears yellowish brown and a finely granular appearance of this lipofuscin is seen. Okay, and the second image is the electron microscopic image. So ultrastructurally, the center one is the nucleus. Okay, so surrounding which we see this electron dense granules, right? So these are the lipofuscin granules actually. So this constitutes the lipofuscin. Okay, so the characteristic location, whenever they mention an yellow-brown pigment in a perinuclear location, they are talking about lipofuscin. So coming to the next pigment, which is hemosiderin. Hemosiderin is nothing but an iron pigment. So in conditions of iron excess, whenever there was an excess of iron, this iron pigment will accumulate in the body. Either it could be a local cause or a systemic cause for this iron excess. So we all would have experienced a contusion or a bruise. It is nothing but a blunt trauma. So in a blunt trauma, what happens? The blood vessels, the capillaries get damaged. So the RBCs will get extravasated. It will come out of the vessel, and these extravasated RBCs are in turn taken up by the macrophages, which will phagocytose the hemoglobin present in the RBCs. So hemoglobin contains iron. So this hemoglobin ion will be stored in the macrophages. So that is one of the causes of hemosiderin, local excess of iron. So inside the macrophages, we are seeing this hemosiderin. Normally hemosiderin laden macrophages are the source of iron during erythropoiesis in the body. So hemosiderin laden macrophages are normally present in the bone marrow, liver or spleen, wherein hematopoiesis occurs. Okay. But whenever there is a pathological systemic increase in iron, like in a hemosiderosis, that is what we call as a hemosiderosis, whenever there is an excess iron systemically, so that is called as a hemosiderosis. So therein the iron again gets deposited at various tissues. So what are the causes of this hemosiderosis? So firstly, we have hemolytic anemia. It is a type of anemia, and as the name suggests, hemo means blood, lysis means lytic means lysis. So it is getting broken down. So whenever RBCs are getting broken down in excess, so the RBCs contain hemoglobin, and from hemoglobin iron is present. So this iron gets stored in the body. So in conditions of hemolytic anemia, or when the patient is receiving repeated blood transfusions, so again iron is being received. So in both of these conditions, we get to see hemosiderosis. Also, there is something called as hemochromatosis. Hemochromatosis is an inherited disorder of iron metabolism basically. So there are various genes involved in iron metabolism, the genes which are responsible for iron absorption from the gut. So some of the genes are HFE gene, then we have hepcidin gene, then we have hemojuvelin gene, HJV gene, and then transferrin receptor 2 gene. So any of these genes could be mutated, which results in a condition called as hemochromatosis. Hemochromatosis. So hemochromatosis is a triad in which we can have various organs affected, basically the liver, pancreas and skin. This is the classical triad. Other than this, we can also have heart which can be affected, endocrine organs which can be affected, or the joints also. So any of these organs can be, in any of these organs we can see iron deposition. So in liver, it classically produces a micronodular cirrhosis. Okay. In liver, due to the iron deposition, the iron is basically it can cause free radical injury. Like we spoke about Fenton's reaction, right? So iron is directly toxic to the cell and cause free radical injury, and it can result in micronodular cirrhosis in the liver. In the pancreas, again, it can affect the pancreatic cells, and here it can result in diabetes mellitus because the islets of Langerhans can be affected. So insulin production will be decreased, and that will result in diabetes mellitus. And in skin, we can see deposition of a pigment which is basically a melanin pigment more than a hemosiderin pigment. Okay, so melanin more than hemosiderin to be accumulated in the skin, and that imparts a slate blue color to the skin. Okay, we'll see the picture of this in the skin pigmentation and when we are speaking about melanin pigment. Okay, so this is the image in which this is the hepatocyte. The first image is of that of a hepatocyte's liver image. So in which we can see this yellowish brown kind of a granular pigment, right? So this is nothing but hemosiderin. So hemosiderin is a refractile pigment which is golden yellow to brown in color. Okay, and the most important question about hemosiderin is it stains with Pearl's Prussian blue. Okay, so Pearl's Prussian blue is the stain which stains iron. So anywhere we read about iron in pathology, it is always highlighted with the Pearl's Prussian blue stain. Okay, so we saw about hemosiderin, which was nothing but ferritin only. Ferritin, which is the storage form of iron. The ferritin micelles are getting accumulated into hemosiderin granules, and they stain with the Pearl's Prussian blue. Also, hemosiderin laden macrophages I told, right? So in many places we can see these hemosiderin laden macrophages. One such example will be an endometriosis. So endometriosis is nothing but the presence of the endometrial tissue outside the uterus. Okay, so this it is comprised of endometrial glands. It could be endometrial glands or the endometrial stroma, or along with that, we can also have hemosiderin-laden macrophages. So these three components comprise endometriosis. 2 out of these 3 features must be present to call it as an endometriosis. So here again we can see hemosiderin-laden macrophages, and that can be highlighted with the presence of with the Pearl's Prussian blue stain. Another place wherein we see these hemosiderin-laden macrophages, which are given a special name called as heart failure cells. These heart failure cells are nothing but pulmonary alveolar macrophages only, which have taken up the hemosiderin, and it is classically seen in a condition called as pulmonary edema. So moving on to the next pigment, which is bilirubin. Bilirubin, we all know it is the breakdown product of hemoglobin. So hemoglobin, when it breaks breaks into heme part and globin part. So globin part is the protein part which will go to the protein storage pool, while this hemoglobin heme part, which is the one which contains the iron, again iron will go and go to the storage pool. So the rest of the heme part is broken down into biliverdin, which is a green color pigment, and then to bilirubin. Okay, so after this, the bilirubin it is taken up by the liver, wherein it is conjugated, and after that it is excreted into the bile, into the intestine, and gets excreted from the body. So whenever there is some problem in this excretion pathway, or whenever there is an increase in the formation of bilirubin, the excess bilirubin can be seen in the hepatocytes. So this again has a yellowish brown color tinge only. So this is classically seen in cholestatic conditions. So cholestasis, in cholestatic liver disease, that is cholestasis is nothing but the bile has been stasis in obstructive conditions. So what happens, the bilirubin is not been able to excrete into the intestine. So inside the liver itself, the bilirubin starts accumulating. So it can be present in the bile ductules in the portal tract. The second image is the one which is showing these bile plugs or bile lakes. Okay, bile plugs and lakes. So this is the picture we seen in a cholestatic liver disease. Also, this bilirubin can be present inside the inside the hepatocytes or the hepatic biliary canaliculi as seen in the first image. Okay, and this bilirubin can be highlighted by a special stain called as modified Fauchet stain. This Fauchet stain will give a emerald green color. So here again this emerald green color is the bilirubin which is being highlighted in the bile ductules. Okay, so bilirubin again is a yellow brown pigment which is present in the liver, especially in cholestatic conditions we can see it, which is highlighted by the Fauchet stain. So moving on to the next pigment, which is melanin. Melanin, we all know it is the pigment which is responsible for our skin color, right? So it is normally present in the basal layer of the skin. We have the melanocytes which contain this melanin pigment. It is a endogenous blackish pigment. Okay, it is an endogenous brownish black pigment. Melanin is derived from tyrosine by the action of tyrosinase enzyme. So here the first image is that of a malignant melanoma. It is nothing but a malignant tumorous condition where of the melanocytes. Okay, so here again we can see this brownish black pigment, and these are the tumor cells which are having this prominent nucleoli, which is one of the classical features of a malignant melanoma. So this malignant melanoma again contains the melanin pigment. Not necessarily melanin pigment should be present for a malignant melanoma, but mostly we do see melanin pigment in a malignant melanoma. So what are the special stains in which we can highlight the melanin pigment? So we have two stains, especially the Fontana-Mason stain, which imparts a black color to the melanin pigment. So the second image is the highlighting the basal layer of the skin. The melanin pigment is being highlighted by the Fontana-Mason stain. So the next image, the third image is the small stain, which here gives a emerald green color to the melanin pigment, emerald green color. Fauchet stain gave an emerald green color to the bilirubin pigment, while small stain gives an emerald green color to the melanin pigment. So when I spoke about hemosiderosis, do you remember I was saying something called as skin pigmentation, right? So that is called as bronze diabetes. So in hemochromatosis, we have skin, liver and pancreatic involvement. In liver, I told it was nothing but the micronodular cirrhosis, and in pancreas, I told it had a diabetic mellitus because islets of Langerhans are being damaged by the deposition of the hemosiderin. So in skin, I told it will have a deposition and it will lead to a color called as slate gray in color. So the slate gray color deposition is not because of melanin more than hemosiderin. Okay, always remember it is melanin more than hemosiderin. So in the option, if you have melanin, so the first thing you will have to take will be a melanin pigment. So another example wherein melanin is present is normally in the basal ganglia. In the basal ganglia of the brain, there is dopaminergic neurons. So substantia nigra is the basal ganglia part wherein dopaminergic neurons are present, and these dopaminergic neurons are black in color because they contain something called as neuromelanin. So this neuromelanin is normally present in the healthy patient. But in Parkinson's disease is a disease in which there is decrease of the dopaminergic neurons in the basal ganglia. So in Parkinson's disease, these dopaminergic neurons are being lost. So in the first image, this area is the normal substantia nigra area which is appearing black because of the presence of neuromelanin. But in Parkinson's disease patient, the second image, we can see it is appearing pale, right? Pallor of the substantia nigra is seen in Parkinson's disease. That is because of the loss of dopaminergic neurons which had the neuromelanin. So what is the classical thing which we see in a Parkinson's disease? So it is a Lewy body. Lewy body is nothing but an inclusion present in the neurons only. Here can you see the brownish black pigment? It is nothing but the neuromelanin present inside the neurons. And this center you can see an inclusion which has a halo, right? This pale colored surrounding the center part is dark, while there is a halo kind of thing surrounding it, right? So this is a characteristic appearance of a Lewy body. This Lewy body composition is a alpha synuclein. So we'll be reading more about it during CNS chapter. So just remember, Parkinson's disease is a disease in which there is loss of dopaminergic neurons containing neuromelanin, and the characteristic finding we see in a Parkinson's patient is a Lewy body which is composed of the alpha synuclein. Okay. So the next pigment we'll be speaking about is a homogentisic acid. It is also a black color pigment which results from a autosomal recessive condition called as Alkaptonuria. So Alkaptonuria, in which there is an enzyme deficiency, and it is an inherited disorder. So the enzyme which is deficient here will be a homogentisate oxygenase. So because of this, the homogentisic acid is getting accumulated, and this accumulated homogentisic acid is going to get deposited in various places like skin, cartilage, and that is called as Ochronosis. Okay. So the first image is the one which is showing this deposition of the homogentisic acid, which is a black pigment in the sclera of the eye. So the second picture is the one which is showing the characteristic deposition of homogentisic acid in the ear cartilage. Okay, so it gives a bluish black color to the ear. And next image is that of a classical history of this Alkaptonuria will be given like this. The urine on standing becomes black. So this is the normal urine. So when you keep the urine fresh after micturition, the urine will appear yellow only. But on standing, that is on exposure to air, the urine will become black in color because of oxidation. So this is the classical history which will be given for an Alkaptonuria case. And also they will give it like a baby, in which the diaper, the mother notices that the diaper is black in color. So again, the urine which has been passed was present for some time, which on exposure had turned black in color. So whenever they are giving such a history, they are speaking about Alkaptonuria. Okay. So moving on to the last pigment, which is copper. So copper, we all know it is a brownish pigment. So when does copper get accumulated? It gets accumulated in a condition called as Wilson's disease. The Wilson's disease is a disease in which there is ATP7B defect. So because of this defect, copper is not being able to excreted into the bile, and it is not getting incorporated into its transport protein, which is ceruloplasmin. Okay, so we'll be reading about Wilson's disease in detail when we are discussing liver chapter. So I'll just give a brief introduction over here. So ATP7B defect is there. So copper is not getting excreted into the bile. So copper is getting accumulated inside the liver. So here again, it is a classical triad involving the liver, brain and the eyes. So copper deposition is seen in these three organs mainly. So in liver again, it will lead to cirrhosis. It can also lead to hepatitis, which could be either acute, chronic or a fulminant hepatitis. So in anyways, the final end result will be a macronodular cirrhosis over here. So we saw in hemochromatosis, it was micronodular cirrhosis. In Wilson's disease, it is macronodular cirrhosis. Why does cirrhosis happen? Because liver is getting damaged. Like iron, copper also, I told it was involved in Fenton's reaction. So that is again directly toxic, resulting in free radical injury. So hepatocytes are getting damaged, and that will lead, end result will be that of a cirrhosis. So in eyes, this copper can again get deposited, and that is producing a classical picture of a Kieser-Fleischer ring, okay, that we call it as KF ring. So here the copper is getting deposited in the Descemet's membrane of the cornea, okay, Descemet's membrane of the cornea, in which there is this copper deposition, and that will be seen as an yellow-brown colored ring, okay, yellow-brown colored ring. On slit lamp examination also we can see this. In brain, especially the basal ganglia, which is the putamen, this putamen region which will undergo atrophy and cavitation in a Wilson's disease. So here again there will be neuropsychiatric manifestation because basal ganglia is being involved. So these patients will have neuropsychiatric manifestations. Remember, Wilson's disease will have neuropsychiatric manifestations. So what is the special stain which can be used for staining copper? It is rhodonine and rubianic acid. Here it will stain brown in color, okay. And Orcine stain, don't confuse with this Orcine stain. Orcine stain actually stains ceruloplasmin and not copper, okay. Ceruloplasmin is the carrier protein for copper, and that is stained by Orcine, while copper is stained by rubianic acid and rhodonine stain. Orcine also stains elastin and hepatitis B antigen. So HBsAg antigen, which is the hepatitis B antigen. So that is also stained by this arsine stain. So that is another MCQ. So remember. So till now we had seen various pigments. So first pigment, which we'll see about the black color pigments. The first black color pigment was carbon, which was an exogenous pigment. Then we saw about melanin pigment. Then homogentisic acid, which was seen in the condition called as Alkaptonuria. So coming to yellowish brown or brownish color pigment, first thing we saw was lipofuscin, which was the telltale sign of free radical injury, right? It was a wear and tear pigment, characteristically seen in a perinuclear location. Then we saw, mainly in the hepatocytes, we saw Hemosiderin pigment, then copper pigment and bilirubin pigment. So all of this had an yellowish brown color. So whenever they are in the history, they are mentioning a Pearl's Prussian blue reaction, it means they are mentioning about iron pigment, Hemosiderin. Whenever they are giving a rhodonine stain, a brownish colored appearance on a special stain, then they are talking about copper pigment. Whenever they are telling about Fauchet stain or a cholestatic kind of history is given, they are speaking about bilirubin. So all of this comes under the differential diagnosis of each other. Okay. So in the next class, we'll be seeing about other intracellular accumulations, that is lipids, proteins and glycogen. So that's it for today's video. I hope you like this content. If you like my content, consider subscribing and sharing it to your friends who might also benefit from this video. Thank you.